Dr. Iman, when you're ready, my dear,
Yeah,
please let
doctor.
me know.
Yeah, okay. So I'm ready.
I think you are 10 minutes.
Yeah, I'm Iman, one of the candidates. I read the instructions. I'm ready for discussion.
So I can see that our case today, Miss Sarah Jones, suffered from a recurrent pregnancy loss by definition. So she had been seen before in the clinic and we arranged investigations and it seems like all the blood work came as normal. But the scan found to show the partial uterine septum. Okay, so the scan was done by the 2D. So, from your point of view, what do you think the best management for this case?
Yeah. So you mean I should start by the management, doctor, or shall I go for ice bar?
What you
For me,
believe?
for me. Yeah, yeah.
Please go.
So for me, I will start for ice bar. So as you mentioned, as a patient, she is 30 years old with the three recurrent cancer miscarriage, and all her investigation revealed were normal, apart from the 2D scan revealed septate cancer uterus. So after history examination and investigations, and all were done in the recurrent miscarriage health clinic. So I will counsel as a patient about the case, and usually in the presence of my consultant. So we'll discuss the case and we'll go for further investigation. So, like, I will start by 2D. For 2D, I want to know if there is only septate uterus, if there is any other abnormality, like if there is a urinary tract abnormality also. And if there is a possibility of facility for 3D dimensions ultrasounds, we can go for 3 dimensions ultrasounds as further investigation. If it's not available, probably we'll go after counseling with the radiologist, we'll go for MRI.
Okay. Okay, so you said that you would like to start by the history and the examination of the case. So would
Yeah.
you please tell me what point in the history you would like to cover?
Yeah. So in the history, I would like to go further about the miscarriage, or I mean, it is a spontaneous yes, miscarriage, the time of miscarriage, whether it's first trimester or second trimester, whether it is painful or painless miscarriage, and if the recovery for each miscarriage. There is also, I would like to ask if there is a result for a miscarriage, if suppose she is third, if there is any chromosomal study for the miscarriage, if further investigation other than. However, this investigation, I think, is good investigation since reveal only we need for chromosomal study. Apart from that, it's okay. And also I would like to ask
How you will
patient.
perform the chromosomal? Okay,
Yeah.
so how you perform the
So
chromosomal studies?
sorry, doctor.
How you will perform the chromosomal studies?
So after third trimester, usually they will send it for the chromosomal study. I think array investigation. There is a specific, I forget the name, microarray investigation to go for a concept chromosomal study. If there is abnormality, we'll refer her to the genetic council. If there is no abnormality, we'll go with the what we have available here from the investigation. Like it could be concomitant, but most if it's normal, then it will be most likely it will be congenital abnormality of the uterus, the cause of her.
So what
Also,
would you suggest as a management of the septate uterus?
so septic uterus is usually there is a different possibility we'll discuss with the patient about septic uterus. Either it could be just conservative treatment, and for further investigation, for further pregnancies will go, and there is possibility of miscarriage again, but it could be the possibility that the miscarriage will increase. I mean, gestational age will increase in each subsequent pregnancy, and also we'll discuss, we'll check if there is any. Um, uh, I mean, if there is any cervical changes, if there is any diameter of the cervix in subsequent to pregnancy, we need also monitoring of cervical length during subsequent to pregnancy. Or we'll go for possibility of hysteroscope resection after MRI. We'll go for hysteroscopes resection of the septate uterus if there's any possibility for it. But we'll discuss with the patient about the risk and the complications. It could be a result from septate removal under hysteroscope, through the hysteroscope.
Okay, so what are the risks associated with it, and what are the proposed benefit of the surgery?
Yeah, for usually for hysteroscopes, one will go under has a GA, and to know to know the contents of the inside of the uterus, endometrium, and the length of the septate, and if there is possibility for resected. It could be there is possibility of resected. However, there is complications. It may be early and maybe late complications. Early complication related to GA and related to, but it may be there is possibility of perforations, bleeding, also maybe later subsequent complications. It will include there is risk of adhesion when you remove the septum.
Okay, so if you leave the septum, so what is a possible complication or the implication of the septum in the following pregnancy?
Yeah, so as for septum, usually if you leave with the septum, there is a possibility that the pregnancy will increase in gestational age and subsequent to pregnancy. And also, maybe there is possible not only for miscarriage, the possibility of for preterm labor, it could be premature rupture of membrane, it could be malpresentation, it could be even if you remove, I forget to mention, if you remove the septum, maybe there is a risk of adhesion. Adhesion also is associated with risk of miscarriage, risk of preterm labor, placenta adhesion, all these complications. So even later on, there is VPH, ABH, something like that.
Okay, so do you have any specific recommendation for the surgery?
It's usually surgery hysteroscopes. I think it's a type 1 hysteroscopes, which is under GA, and probably will go used by resectoscope. It may be more than one session, not only according to the conditions of the surgery. It may be not just one session, it may be more than one session for removal of it. And that's all, I think. But if the possibility there is with the septate uterus, maybe there is possibility with other congenital abnormality like cervical incompetence, probably will go for suturing of the cervix during subsequent pregnancy.
So what is the reason for that?
It may be something related to the part of congenital abnormality, or it may be as a part of what they call it. It's it could be I really it's maybe no evidence, but maybe no evidence unless it is confirmed by frequent ultrasounds, or because if there is history of 3 recurrent miscarriage. So from history we have 3 recurrent miscarriage, and if especially it's second trimester miscarriage, we can go for cervical sarcology from history point, especially if it's second trimester miscarriage. Yeah.
Okay. Anything else would you like to add?
At present, doctor, no, nothing. Yeah, nothing. But as I mentioned, it's probably it will go for removal of the symptoms. Will be more. We'll discuss with the patient the risk if she become pregnant. Again, there is a risk of complication during subsequent pregnancy, and we need consultant-led unit, and we need probably maybe according to the surgery, maybe will it maybe there is possibility will go for. Cesarean section is not at the present time, but it may be there is possibility if there is any complication, we'll go for cesarean section in consultant units.
Okay.
Yeah. And it is multidisciplinary approach, by the way, doctor, because we need radiologists and a gynecologist, and probably later on would be anesthetist and pediatrician when she's become, neonatologist if she's become pregnant later.
Okay.
Yeah, that's all.
Okay, so now your time is over.
Okay, thanks.
Exactly 10 minutes. Okay. Thank you very much, Dr. Iman, for the good chance of presenting this task. I can see that you have a good knowledge, um, and let me say something, okay? Are you stressed a little bit?
Yeah, doctor, long time I didn't present it. Long time.
Okay, but you do have a very good base, so I don't think that you need to be, you don't have to be stressed at all. Okay, just reassured and be calm down. You know why? Because in this exam, in the part three exam, usually the examiner is going to look into how confident you are. So if you are confident in yourself, I'm not saying overconfident, okay? I'm not saying arrogant, but just confident in yourself, okay? This will reflect on the examiner as well. This is one thing. Another thing, it's a part of the, by the way, of the marking, right? That they write how the candidate looks like. So if the candidate is confused or reluctant or speeding off or not organized, okay, so this is all going to affect, okay, the total mark at the end. So be very careful of that. The aim of the testing in the part three, they test you as a future consultant to be. So when you are quiet and you speak with confidence and you have organized thoughts, now you are, a good candidate. This is the standard that they need. And by the way, this is why they call it a structured discussion. So you have to show the examiner your way of thinking, okay, and your approach of management. You have started the task with a very good start by mentioning about this PAR tool, okay? Yes, so I agree with you that it's good that you summarize the task when you start, even if he didn't give you a lot of the details. By the way, what I have collected from your friends, that there was a lot of investigation results are there, but this is the summary, of it. So um, it will be a good chance, okay, to present the task with this part tool at the beginning. So well done. It's a good beginning. Regarding the management of the task, the first question when I asked you what is the suggested or proposed management, right, according to the guideline. So you have said that you are going to cover the history, examination, investigation, and you just name it, okay? So you just said history, and then you said examination and investigation, correct? This is what you have done.
Yeah.
So look here, you need to give me a justification of everything you are suggesting. How? You need to tell me in the management, okay, of this case, I would like to know more about her history, especially the obstetric history, right? Like, for example, if she have any living children, okay, about the timing of the miscarriage, as you said, okay, first trimester or second trimester miscarriage, was it preceded by bleeding or it was a missed miscarriage, and how it was managed, each one of them, okay, and if there was any complication after this or not. I would like to know more about her medical condition. If she have any other disease, I can see that the thyroid test is positive. The hemoglobin A1C, is normal. Hemoglobin A1C is within normal, okay? But if there's any chronic condition, if she having any treatment, right? Because you need to know in general about this case. Any case that might have a surgery, okay, in your management, you need to also mention if this case had any surgery before or not, right? So this is the question that you need to ask. Then you will just quickly, okay, mention the important point in the history that might be related to the recurrent miscarriage because you are in the dedicated recurrent pregnancy loss clinic. It shouldn't take like more than few seconds from you when you mention about her social history, like if the kids is smoker, for example, or she's drinking alcohol, okay? So quickly about her social history, about her habits, right? And important also that we know about her bodybuilding, if she had any allergies and all. Okay, then quickly you will move to the point of what is the examination required in this case. So what are you looking at the examination? You said examination. So what is the point in the examination you want to know?
It could be possibly body mass index, blood pressure, abdominal examination, just in case. BV, I will go for BV examination just to look. It maybe there is some abnormality in the cervix. Yeah, could be. There is possibility.
Okay, so for yourself as a doctor, okay, so we don't actually have in the examination measure the weight or the blood pressure ourselves, of course, okay, but
Yeah.
we do. Yes, a general examination, abdominal and vaginal examination. Okay. If you have a certain point in the examination that you suggest, you have to mention. Okay. Again, as I tell you, in the part 3 exam, everything need to be justified. Okay. So I'm suggesting, for example, full blood count. Why? Why full blood count? Looking, for example, checking for anemia, hemoglobin. Okay, so why don't you only request hemoglobin? Okay, why the full blood count? So I have to justify. Okay, full blood count. Look, for example, okay, I'm screening a patient for thalassemia. Okay, so looking for the RBCs, the measurement, for a patient for thrombocytopenia, I'm looking to the platelet count. So whenever I say something in the part 3, suggest something, okay, I justify it. Okay, this is a rule in everything. So when I say examination, it's not just the examination. Tell me, what are you looking at in the examination? Okay.
Yeah.
So I'm coming to the point of investigation, right? For the 2D scan, usually will be a pelvic ultrasound. Okay. So it was a good point from you that you suggested or looking at the renal abnormality, because 25% of these patients might have a renal abnormality in the same time. So if you suggest a further investigation, right, it will be the 3D ultrasound, and this is a recommendation by the guideline in the TUC article. Okay, so very important, okay, that we focus on the point when we speak to be structured. Okay, whenever I say something, I will justify it. Further investigation, if you suggest, okay, further investigation, you will suggest abdominal, okay, ultrasound or MRI for the associated renal anomalies. Okay, so this is not something you only look at the 2D. Okay, this is something that you will request it. This is something that you will search for. Okay, so the importance of the 3D ultrasound in this case is very important. As we said, nowadays it's a gold standard, or this is the suggested by the guideline, rather than in the past we used to say MRI, hysteroscope, but now it's the 3D. And very important, okay, that you want to know about the type of the septum, right? Whether it is partial septum or it's a complete septum, correct? So very important, okay, that you again explain to the examiner, justify what are you looking, for
Yeah.
by requesting this investigation. Okay, so I'm requesting this investigation for what, right? So
Yes.
it will give me a better viewing of the uterine cavity. It will show me, okay, whether the septum is a complete septum or a partial septum, correct? So then you will come to the point of when you say management, you have to mention about the other colleagues involved in the management. Okay, so the point of the NDT, you have remembered this at the, I think, last minute of the station. Please remember, whenever you start management of any case, that you don't forget about your colleague roles. Okay, so you're securing communication with colleague by this way. Now I have a patient, okay, with a recurrent pregnancy loss. What is the evidence say about that? Okay, is it debatable? Okay, is it recommended to do the to remove the septum surgically? Okay, or is still not concluded? Actually, it is recommended for the cases who suffer from a recurrent pregnancy loss, surgical treatment of the uterine septum. Okay, and I'll tell you, okay, regarding the recurrent pregnancy loss guideline, this is not the main source of this station. Okay, this station comes from the TUG article and from the NICE guideline. There is the NICE guideline, okay, for the management of the uterine abnormalities, such as the uterine septum. And here I give you like a screenshot from it, okay? And the surgery that is proposed in both the TUG article and the guideline is the hysteroscopic metroplasty, okay, of the uterine septum, right? So this is the management, right? This is the proposed management, and it will be done by the hysteroscopy. It's better. It's a type of reconstructive surgery, okay? And what we call it, what is the famous name of it?
I don't know that name. Yeah, just
Anybody
hysteroscope.
know?
Hysteroscopy.
Strassman metroplasty. Okay, so this is the technique that is recommended. Okay, and the guideline also and the TUG article suggested or advocated the use of the scissor over the resectoscope. Okay, while you are performing this in means of higher subsequent pregnancy rate. So this is very important, and this is the part of the answer where the examiner are looking at. Okay,
Okay.
so
Yeah.
allow me, my friends, just show you this part from the TUG article. Okay, so this is the TUG article that we are speaking about, or the source of this. And I think that we do have a very lovely infograph that I will show you again. Okay, this was published in April 2024. And of course, you know, the part 3 exam is very updated. Okay, so they can ask questions about the guideline that, you know, released 1 week before the exam, unlike part 2. Right, part 2, it takes like 6 months, but for the part 3, they are, you know, very updated. So here in the septate uterus, we see that we organize ultrasound scan for the renal tract, no clear evidence to support routine septal resection. Septal resection can be offered to women with a history of recurrent pregnancy loss or a recurrent miscarriage, right? So this is a part of the summary of it, okay? And of course, we have to counsel the woman, okay, prior to or during the ART regarding this, that counsel regarding increased risk of miscarriage, okay, and before the pregnancy, counsel about increased risk of miscarriage, preterm labor, malpresentation, and low birth weight. Refer to obstetrician with expertise in preterm prevention. This is regarding the management of the septate uterus. Okay, now we'll come here to the part where the evidence, okay, recommend for the septate uterus. Okay, so you know, every one of you guys, that this is the most common congenital anomaly that we see in the uterus, right? And the group, okay, of the congenital uterine anomalies, okay, or sometimes unknown variant, is all managed like with the same thing. The septate uterus is a common uterine anomaly, the most common uterine anomaly, and may affect as 1%, 1 in 100 in the female population. The septum may be partial, with the effect ranging from small, right, or complete septum where it reaches the cervical canal. Renal agenesis is found in 25% of women with the septate uterus. Septate uterus is accurately diagnosed using 3D ultrasound, and the examiner in the exam asks about what is the investigation of choice. Okay, so the answer is the 3D, which is less costly than the MRI and less invasive as well than the combination of hysteroscopy and laparoscopy. Compared to women with other congenital anomalies, women with septate uterus have the worst obstetric outcome. So the obstetric complication, right? Because part of your counseling to the patient that you mentioned about the options of treatment and no treatment, correct? So if we left the septum, and what is the the implication of the pregnancy?
Worse.
Yes, so with significantly increased risk of first and second trimester miscarriage, preterm labor resulting in term life birth rate of only 30%. So if she did not have surgery, she will have only 30% of having a baby. Okay, this is through to occur as the septum provide a poor implantation for the pregnancy. Then they will speak about the hysteroscopic metroplasty, okay, or the hysteroscopic transcervical division of the uterine septum, okay, has gained traction, okay. However, a recent randomized control study incorporating 80 women with septate uterus with a history of either subfertility or pregnancy loss or preterm compared septal resection and conservative management and found no significant difference in live birth rate between the two groups. However, they come again and they speak about that this study was sample was limited and recruitment was over a long period. Okay, so nowadays, what is the final recommendation? The final recommendation, if you have a case of recurrent pregnancy loss, this is the one where we will advise the surgery, okay? Otherwise, for example, if you have incidental finding, okay, of a uterine septum, so the evidence say that maybe done, maybe not done, will be individualized cases, right? But now, okay, the NICE guideline, again, okay, confirm the same thing. Okay, so when here they speak about the individualized approach to the task, okay, except this woman, in women with a history of recurrent miscarriage, the evidence on efficacy is adequate to support the use of this procedure. If surgery to be considered, a recent network meta-analysis suggests that the hysteroscopic septoplasty with scissors, okay? So very important because the examiner asked about the surgical technique, okay? Which one you prefer. So you will prefer using scissor, okay, over the resectoscope, okay? Is associated with higher subsequent pregnancy rate compared with resectoscopy. Okay, friends? So this is where the evidence come, okay, to the best answer of this task and about how are you going to suggest or the proposed management of this task. Of course, the proposed management is based on evidence, okay, and regarding the outcome of this patient, of course, the procedure itself, it's a surgery and no surgery without risk, correct? So what do you think the overall risk of the surgery, Dr. Iman?
Yeah, there is possibility of complication during the time of surgery, like it could be bleeding, perforation, electrolyte imbalance, probably GA, and infection. And later on, there is probably possibility of adhesion formations. But he used scissors. Yeah, okay. But there is possibility either subsequent miscarriage, preterm labor. There is possibility adhesion of implanted pregnancy to the septum or the remnant of the septum after maybe there's remnant of it after division.
So I liked, okay, at the time you're presenting the task, I liked your way when you speak about that there is immediate, okay, um, complication or there will be a delayed ones, right? So let's start, my dear, by what could happen after the surgery immediately or the complication during surgery, okay? So let's speak about the complication, the surgical complication first, okay? And then we'll go to the point on the implication of the future pregnancy, okay?
Yeah.
So regarding the complication that can happen from a surgery, and this surgery is a hysteroscopic surgery, right? So the general complication of hysteroscopy is there, okay? It will be found there. So like, for example, if you are using, okay, a certain medium, Okay, so it might be also at risk, the woman might be at risk of fluid overload during the hysteroscopy. If you are using something like glycine, however, nobody is using this now, but anyway, okay, will be associated with hyponatremia, for example. Generally, okay, guys, you can't see the screen, I'm sorry. Okay, so generally, there is a risk of uterine perforation during the hysteroscope, okay, and this is 1%, okay, and 1% means it's common. Intraoperative bleeding, okay, with the interruption of the procedure was reported in one of each 973 women. Excessive bleeding was reported in 1% in women. In the case series of 170 women, they found two out of 170. This was managed by intrauterine balloon catheter kept in situ for 4 hours. Okay, cervical laceration. Okay, was reported also by like 1%. Okay, so those are the effect, okay, or the complication that is related to the surgery itself. How about in the future? Okay, they found that there is risk of uterine rupture during pregnancy or delivery. Okay, and there is also formation of uterine synecdoche after hysteroscopic metroplasty, and this is reported in 2%. Okay, 2% is common. And then there is a risk of pregnancy. However, it was ectopic pregnancy. However, it was one case report, right? There is like uncommon risk, okay, about pulmonary edema that was reported after such surgery. So here is the safety from the NICE guideline, okay, because again, what I have got that the examiner asked about the risk of the surgery in details, okay?
Clear, doctor.
Other risk that is, they consider it as theoretical. Adverse event, my dear, is incomplete resection of the septum, infection, placenta accreta and percreta afterwards in the pregnancy, negative effect on fertility through damage to the endometrium, and terminal effect on the uterine and endometrial blood flow. Okay, so this is all about the task, my friends. Any questions so far? I was preparing some good pictures for you guys, but I think you are too knowledgeable for this basic information.
Maybe one time they will bring this picture and they will have a case discussion about it in Hamas. They will do it.
Yeah, they can do anything. You know,
Yeah.
in the part 3 exam, actually, they are testing more than your own knowledge or your theoretical knowledge. Sometimes they just test your way of thinking and the approach of management task and your ability to discuss, you know, relevant information about task and collecting, you know, information from the result that given to you. Okay, so this is also part that will be tested in this exam, especially in the structured discussion.
Yes. Okay. Thank you, doctor, for your
Thank you
case
very much.
and base evidence, really, the discussion. And even when you comment about anything on base evidence related to the BDF. Okay, thank you, doctor.
Thank you, my dear friends. Just wanted to review the evidence with you, okay, because sometimes people are a bit confused regarding what is the best management of this case. It was mentioned in some places or in some publications that it's still there is no benefit or no, leave it for conservative management because you know the conflicting result from the studies. So that's why people are a bit confused also about the management of the task. However, it was a recent TUG article, as you can see, published in the April 2024, and there is also a NICE guideline, okay, for the recommendation of surgery and for the risk factors. So guys, I would advise you all that you go through it, okay, go through the TUG article once, go through the NICE guideline once for the preparation of this task. This is, as you can see here, Okay, this is infograph by Emers UG. This is to show you like a summary, okay, for the TUG article about the gynecological pathology and assisted reproductive treatment. And this is include the summary of evidence for each one, okay? So this is regarding, for example, the septate uterus here, okay? Just a quick summary, okay, to remember. For the septate uterus is the most common uterine anomaly, and it affects 1% of female population. Renal agenesis is found in 25% of the women with septate uterus. Women with septate uterus have the worst obstetric outcome, significantly increased risk of first and second trimester miscarriage and preterm labor, resulting in a term live birth rate of only 30%. The evidence on efficacy is adequate to support the use of hysteroscopic metroplasty of uterine septum in a woman with a history of recurrent miscarriage only. Analysis suggested that the hysteroscopic septoplasty with scissors is associated with higher subsequent pregnancy rate compared with the resectoscope. Okay, thank you very much, my dear friends. And I hope that our quick session today was useful. Okay.